Welcome to Navicent Knows Health. I'm Cindy Busby, and I'm here today with Dr. Erik Schneibel. He's a board-certified cardiologist and also board-certified in interventional cardiology. And today we're going to talk about his practice in Central Georgia. Dr. Schneibel, thanks so much for being with me.
Thanks for having me.
Would you first let our audience know the type of conditions that patients are referred to your office for? What are they experiencing physically when they get a referral?
Sure. The most common symptoms that we deal with are symptoms that can be coming from coronary artery disease or plaques and buildup in the coronary arteries that supply the heart muscle. And the most common symptoms that we encounter are folks that have chest discomfort, shortness of breath. Sometimes people present with palpitations or feeling like their heart's skipping beats. And those are probably the three most common complaints we get. Now, certainly those aren't always related to heart artery disease, but they can be signs, which are often how we meet patients for the first time.
When it comes to those patients, do you find that it is generally both for men and women, or do you see a disproportionate number of a gender in your practice?
I think that's a great question. So what we're encountering is that we do know that coronary artery disease affects men and women in equal prevalence, if you will. And so what we have noticed, however, is that in coronary artery disease, men tend to be diagnosed more than women do. Mm-hmm. And we think that has a lot to do with the symptoms that men present with are often different than what women present with. So classically, men present more with the typical symptoms of heart artery disease. And the typical symptoms are substernal, or in the center of the chest discomfort that's worse with exertion and relieved by rest or nitroglycerin. And that's the classic description of chest pain coming from the heart. What we find, and for reasons that are a little bit uncertain, is that women more often than men don't always present with those classic symptoms. Mm-hmm. So the problem that we face as a field is that women are less often diagnosed with heart disease than men are. Mm-hmm. And with all of the advancements that we have in treatment for coronary artery disease, it's a terrible thing because there's so many treatments we have, and if you can't be diagnosed, if you're not diagnosed, then you can't be treated with these for these conditions. So certainly men and women both can have coronary artery disease, and it happens in the same frequency.
Once a patient has these symptoms, either men or women, they talk to their primary care physician, they come to your office. What are the general diagnostics that you run in order to do an assessment?
Sure. And so the first thing I think that any physician should do is listen to your patient and let them talk to you and let them really tell you what's going on. And sometimes you can learn more than any diagnostic test by just giving them time to tell you what's going on. But beyond that, once the symptoms, once you get an idea of the symptoms and you start having some suspicion for coronary artery disease, there's a magnitude of tests that we sometimes do. And so there's certainly sometimes we do sonograms of the heart, or what's called an echocardiogram, which gives us an assessment of the heart pumping function. Mm-hmm. Other tests that we sometimes do are stress tests of the heart, which allow us to get a non-invasive assessment of the blood flow in the heart, which can give us insight if there's a blood flow limitation to the heart, which we do in our office. In some patients that have certain symptoms that are worrisome or certain findings on their exam that are worrisome, sometimes we recommend a procedure called coronary angiography, which is an invasive test which allows us to look at the arteries of the heart definitively, which we do in the hospital.
Mm-hmm. When it comes to things like we see today, all the apps you can use to check your heart rhythms and to check your heart condition, is that something that you see people are doing even before they even get to you?
Sure, absolutely, and we see that a lot, and I think it is in some cases helpful. I think depending on what they're using, sometimes they're more helpful than others, but certainly something that's becoming more and more frequent is that folks are using heart monitoring devices that allow us to that sometimes can detect certain arrhythmias with reasonable accuracy. A common arrhythmia that is probably the most common heart rhythm problem in the world is one called atrial fibrillation, or AFib for short, which is sometimes detected on devices like this. Even smartwatches sometimes can detect those, and that can be very helpful in some cases.
How does heart disease progress in the majority of these patients? It's how is it formed physiologically? It is inside of the arteries, the veins and arteries, and we talk about plaque. What's that actual process?
So the process really is certainly, it's coronary artery disease is a vascular disease that can, so certainly people with coronary artery disease can have artery disease anywhere in their body, in their legs, in their arteries in their neck, in their brain, and also in the arteries of the heart. But the plaque is often cholesterol mediated, so cholesterol in the blood can certainly certainly increase the likelihood of developing those plaques. And there's multiple risk factors that can increase the progression of this. And there's independent risk factors, including cholesterol, like I mentioned, diabetes, tobacco, smoking cigarettes is a big cause of it. There's a big genetic component, as well as high blood pressure can increase your risk for that. And the progression varies in patients. Some patients will have mild plaque in their arteries and go years and never have any problem with it. But the problem really becomes when the plaque progresses and becomes a flow-limiting problem in the heart artery, meaning the blood can't flow through the artery well enough to supply the heart muscle with blood.
When a patient comes in with that progression, what are the ways that you can manage it prior to doing an intervention? What are some of the techniques, maybe pharmaceuticals or lifestyle changes that you might recommend first?
Sure, I think that certainly conservative therapy often is the most appropriate therapy depending on the circumstances, and in many cases we recommend, certainly lifestyle modification can be a big component to this for a lot of people. We know that diets that are less rich in animal products and more plant-based diets have been shown to reduce the progression and in some cases even cause plaque regression in coronary arteries. We know that cholesterol control is key, and so often we recommend medications for cholesterol as well as tight control of blood pressure as well as blood glucose in folks that have diabetes. So all of those are geared at preventing progression or stopping this plaque progression in its place. When it comes to symptoms, if patients have symptoms because of some blood flow limitation, there certainly are medications that we can use. Often we use medicines in the nitrate class, which dilate the blood vessels in the heart and improve the flow around those blockages. And so there's probably 3 or 4 different classes of medications that we use to help control the symptoms. But importantly, I think there's the preventing the progression of a disease as well as addressing the symptoms. And the symptoms can be addressed mechanically with interventional procedures or with medications in some patients.
So let's talk about those mechanical interventions. So as an interventional cardiologist, there are technologies that you're using to prevent the plaque from actually occluding or blocking those arteries. So tell us a little bit about that procedure, actually what a patient experiences when you're doing that.
Sure, and so the procedure's come a long way in the past 20 or 30 years since and certainly the technology has evolved a lot and it's become much more comfortable for patients. Traditionally, or in the past 20 years, most of the heart caths in the United States have been done through the femoral artery, which is an artery in the groin. But more and more, there's been the equipment has gotten a lot smaller, and in many cases allows us to access the coronary arteries through the wrist, through the radial artery, which has many benefits. Patients prefer it a lot more over the femoral artery approach because they can sit up right after the procedure. It's more comfortable for a lot of patients. The biggest drawback I tell people with the radial artery approach is that occasionally you'll encounter circumstances that require you to switch over to the artery in the leg. And that probably happens in about 5% of cases where you have to switch over. So we prepare for both possibilities. But the procedure essentially first involves taking a look at the arteries, and you use a catheter, which is a plastic tube essentially that you, under x-ray guidance, navigate into the heart arteries and inject a contrast dye down the arteries. That allows us to image the coronary arteries and see if there are any significant plaques. In the event that there are, if there are plaques that are better suited with mechanical therapy as opposed to medical therapy, in some cases you can take a small wire called a coronary wire that basically lets you put a wire across the plaque, and you can dilate that with a balloon and then put a stent, which is a metal mesh-like structure that basically opens up the artery and provides flow down the vessel.
Anything physiologically when we compared the men to women about the size of arteries? That do women have smaller, physiologically are they smaller? Is that maybe why, as you mentioned, sometimes they're not diagnosed as early, but they're still eligible for the same kind of treatment?
Sure. I think there are some differences in men and women. I think that beyond the diagnostic dilemma that we face, I do see more often in women, especially going through the arm, that the arteries are smaller. So often I look at them under ultrasound and make sure they're suitable. Sometimes I see that women tend to have more spasm in the artery in the arms, which is something that we can avoid by certain medications that we give during the procedures. And sometimes you do see smaller arteries in women compared to men in the coronary arteries. But in general, the treatment, all things considered, the treatment is essentially the same. I think the dilemma really is in the diagnosis in the first place.
From a practical standpoint, Is it normally that you are addressing multiple plaques through these interventions, or is it really just one? If you pass another one on the way, that would be what you could address, but is it normally a one stent procedure, or is it multiple?
You know, it depends on the circumstances. I think certainly we prioritize the most critical areas to work on first. Oftentimes though, when folks have critical blockages in their arteries, almost always they'll have plaques in other areas, but often they're not flow limiting. So the way I usually approach it is you treat the most critical things first, and flow limiting blockages first if they're suitable for treatment with stents. And then often these mild plaques that we see that are maybe 20 or 30% narrowing in an artery, I think that those are often treated best with medication in an effort to prevent them from progressing in a flow limiting problem.
What's the recovery like, radial or groin, through the groin?
Sure. Most of the time, depending on the circumstances, if a patient comes in for an outpatient procedure, and I guess if you just take pictures and you don't see any significant plaques or you don't see anything that needs intervention on, typically if you go through the wrist, patients go home about 2 hours afterwards. If you go through the leg, sometimes it requires them to be flat a little bit longer, which sometimes increases the time that they have to be in the hospital for about 6 hours, I would say. With intervention, typically if a patient comes in the morning and I put a stent in a coronary artery, and they come in as an outpatient, I typically, in most cases, probably about 90% of the time, send them home the same day. But I wait until about 4 or 5 o'clock in the afternoon and monitor them in our recovery area to make sure everything's going well. And then if they're doing well later that afternoon, I certainly send them home that same day.
And this is considered an outpatient procedure primarily?
In most cases.
Okay.
I would say 90% of my patients that come in as an outpatient go home the same day. There's certain exceptions to that. And these are certainly patients that come in for elective procedures, which are different than the patients that come in the hospital in the setting of an emergency.
What, any contraindications once they've been stented, they're home, they've come and seen you 6 weeks after, anything that they're unable to do?
In general, no. I mean, I think in general we recommend patients get back to their lifestyle. There might be a week of downtime after these procedures where we kind of encourage them to take it easy, but then after about a week, patients are back to doing their regular activities, and in fact, we encourage them to get active as quickly as possible.
Well, if someone who's watching today recognizes that condition or even knows they may already have heart disease, what's the best way to get in touch with you?
Sure. So I think the first thing I would say is if you have an established primary care physician that you have a good relationship with, the first thing to do is mention it to your primary care physician, who can refer you to a cardiologist of their choice. If you don't or would like, you can also contact us directly at Central Georgia Heart Center, which is our practice, and we can certainly make arrangements to see you and would love to take care of you.
Okay, perfect. Well, thank you for telling us so much about your practice.
Thank you so much for having me.
And thank you for watching us at Navicent Knows Health. If you'd like to know more about Dr. Schneibel and his practice, please visit us at navicenthealth.org.